The broadcast is now starting. All attendees are in listen-only mode.
Hi, everybody. Thank you for joining us this morning. We are going to get started in probably 1 minute after 10:15, just to give folks some time to roll on to our session. Thank you so much for being here, and I will get us started pretty soon. Thank you. Hi, everyone. We are just about to get started, so thank you so much for being here with us this morning. My name is Anna Guida. I'm the project manager of Empower Idaho, and we're super excited for the final day of our 2021 Southwestern Idaho Peer Support Connection Conference. It feels like just a few months ago we were having our last Southwestern Idaho conference, so this year just sped on by. Again, thank you so much for choosing to be here with us this morning. If you have any questions throughout this session, there are 2 email addresses listed on this screen I'm sharing right now. The first is mine, and the second is our project assistant, Erin's. So please feel free to utilize those if you're experiencing tech issues or if you have questions about CEUs. I am going to pass it along to Matt Hardin, who is our presenter this afternoon, or this morning. Super excited to have him. I guess the one more piece of housekeeping I should include is that there's a chat box and a question box function in your control panel that you'll utilize to ask questions to Matt throughout the session. And throughout the session, Matt will prompt me to kind of read some of those questions. So if your question isn't answered immediately, we'll get to it for sure. Additionally, if you would like a copy of the slides, please send me an email at that email address right there. I'll put it in the chat box and we can get those slides to you. Without further ado, I will pass it off to Matt. So let me just get his webcam set up real quick. There, your screen looks great, Matt.
Awesome. All right. All right, yeah. So thank you everybody for coming this morning, taking time out of your day to come and listen and be a part of this conference. My name is Matt Hardin. I am a licensed clinical professional counselor. I am currently the director of the Southeast Idaho Behavioral Crisis Center in Pocatello, Idaho. So that's what I'm currently doing. I've been a private practice clinician working with mental health and substance use. Before then, while I was getting my degree, I was working as a PSR or CBRS worker, if you're familiar with what that is. A lot of skills building with individuals with chronic mental health. And before then, I was an educator. I worked in early education, loved teaching, loved working with the kids. managed that program for a while. And so that's kind of that's my background. I'm really passionate about teaching. It's something that I'm kind of jumping back into, which has been a lot of fun. And so again, thank you for coming and listening. I really appreciate it. Just one warning before we get into this, Navigating a Crisis is the title. We will be talking about suicide a little bit, nothing super detailed or in depth, but just a warning. I want to make sure everybody's checking in with themselves. If we're talking about things that are getting too personal, always feel free to check out if you need to. Take care of yourself. And yeah. Again, COVID has, we're all here virtually to do this, and slides over Zoom are kind of difficult. There's only 15 slides, and so hopefully I'll be talking and explaining more. There's a few busy slides, but 15, it's not too bad. I watched Dr. Joyner and Dr. Rudd present a while ago, and if you're not familiar with those guys are some of the top individuals on suicide in the country, just fantastic. And they do 2-day-long presentations, and their slides are just filled with so much stuff, and it's so amazing. I was thinking about it the other day. It's like walking into like a temple or a pyramid, and it's full of gold, right? You're like, oh my goodness, this is so much good stuff. This is amazing. My slide, there's 15 slides. I'm hoping to really be the $20 that you find in an old pair of jeans, right? Something that is surprisingly useful, right? Hopefully it's not too overwhelming, and something that can be used right away, and not too overwhelming. So let's see. So the objectives for this presentation, there's 3 of them. Number 1 is crisis recognition. So first off, I want to teach you how to recognize a crisis and how to help someone experiencing one in a couple different ways. It's important to learn if we can preemptively strike before a crisis occurs. That's always the best thing to do. The second one, learning about local and appropriate crisis-related resources. If somebody's in crisis, some of the typical resources, they're just not effective. They just don't work when somebody is elevated and those types of things. So knowing what resources to use when somebody's elevated is super important. So hopefully I can get that information to you. And then lastly, peer support, learning the unique effects of crisis work on the peer support role. We've had a peer support out of the crisis center, and so she's had a really unique view on what peer support is in a short-term center, working with people that are in crisis. And so I've asked her to let me know, and I'm going to present that today of some of her feedback and some of the effects she's seen working in outpatient and working inside of a crisis center. So hopefully a unique look at that as well. So hopefully at the end of this is what you're coming away with. But yeah. So number 1, again, the objective number 1 is to learn to recognize a crisis and how to help someone experience one. And so if we have to recognize a crisis, we need to know, what does SAMHSA, what does NAMI, what do those kind of major organizations define a mental health crisis at? What does the state define a crisis as? And so they define a crisis as any situation in which a person's behavior puts them at risk of hurting themselves or others, and or prevent them from being able to care for themselves or function. And so the key point to this thing, and really to this whole presentation, is that first line, any situation in which a person's behavior, right? That behavior is huge. As peer supports, this is something you're going to be able to easily identify and report on 100%, and I'll show you how, but that's really the key piece. We're going to be focusing on the client's behavior, and I call them clients, whatever you call an individual that you're working with, but I'll refer to them as clients. So the client's behavior that puts themselves at risk of hurting themselves or others, that's really when we start to identify a risk, a crisis, and that's when some major interventions need to happen. So the second is to understand the kind of the course of a crisis. And so we have a bell-shaped curve. The left side of the curve, right, we're kind of at homeostasis, we're at baseline, you know, the level at which an individual functions at on a normal basis. Life's not too chaotic, it's not too boring, this is just kind of where we function at. And then based on whatever events happen, those behaviors that we talk about, and I'll give some examples here in a minute, right, that those behaviors escalate, the peak is the crisis, and then we have some tension reduction at the very end of the crisis. Hopefully there's an intervention to give that tension reduction at the end. But again, behaviors is going to be key, because as we look at Maslow's hierarchy of needs, if you're familiar with this, Abraham Maslow was a psychologist in the 50s, really famous guy, had some great stuff, and he developed this hierarchy of needs, and it was his idea that in order to reach peak human performance, to be the person that we are destined to be, to you know, the best that we can be, self-actualization is kind of the peak of humanity for Maslow. In order to get there, we have to have these other things in place. And the first two are physiological and safety needs. We need those two things before we can have relationships, before we can love, before we can have reach some of these other things. And I agree with that to an extent. I think there are some circumstances that doesn't have to be, but I think for the most part, he was right on. And so again, if we're looking at somebody that's in crisis and their behaviors are putting themselves at risk to themselves or others, we're really looking at that first two rungs of that pyramid. And so if those two rungs of the pyramid are in jeopardy, then we're really going to see those other areas start to suffer long term. And so if you worked with the homeless population, the substance use population, somebody that's in active addiction, you know, these first two rungs are constantly in jeopardy because of the drug use, or because of the lack of safety of where am I going to sleep tonight, what am I going to eat tonight. And if those aren't in place, it's really hard to form you know, intimacy, self-esteem, confidence, to be creative, because all of our energy is put into that safety and to meet those physiological needs. And so that's why crisis, right, when somebody is in that mode, it is so imperative that we act on it and get them back to level, because of the long-term effects on the other parts of these of the pyramid. So this is an example of the curve that I was talking about. So this is an example of somebody with maybe major depression, some suicidal thoughts, which could be incorporated into really any mental health issue. But again, if we look at the curve, we can kind of, hopefully you can start to understand what the curve means and how that looks, right? And so somebody that lives with major depression, maybe they're in active addiction, they may have suicidal thoughts once a day, twice a day, once a week, right? Those suicidal thoughts could be there all of the time, but that doesn't necessarily mean they're in crisis, right? It's unfortunate that their thinking is there, but until we see the behavioral change, right? Because the crisis is defined as any situation in which the behaviors is putting somebody at risk to harm to the self or others. And so it's not until we see the behaviors, right? We have a million thoughts going through our head every day, but that doesn't mean that we're in crisis. But it's when that internal struggle starts to manifest itself outward into our behaviors, that's really when we need to start to, right, our ears need to perk up, red flags need to start going off, and we need to start to step in and intervene. So for this individual, right, maybe they're major depression, and maybe those thoughts are rolling, and the individual starts to develop a plan, right? Just the overwhelming, maybe there's a bigger stressor going on in life, the thought of escaping, you know, some of those things. And so the individual starts to devise a plan, and with that plan starts to withdraw socially because of a lot of the time is spent thinking about it, and it just consumes the individual. And so as they begin to devise a plan, then they start gathering materials for that plan. So maybe they start stockpiling medication, and then they're debating on whether or not they should, and so they start using, maybe they start drinking more than normal. Right, alcohol reduces our judgment, right? It makes us more impulsive, and so we see an increase in substance use, which then affects sleeping, hygiene, a lot of these behaviors, and then of course some of the extreme red flags for suicide. Phone calls to say goodbye, giving away possessions, some of those things, and then that peak of the crisis, ready to take the meds, right? But we can see that escalation of behaviors, and this may be over a month. This could be over a week. Really, the time frame is kind of all over the place, but there is an escalation of these things. And then hopefully there's an intervention, right? It could be a friend call, it could be the dog comes up and nudges the individual. Really, any kind of intervention that slows the process down, that distracts the individual. When it comes to suicide, distraction, slowing the process down, all of those things are effective and clinical, just slowing it down. So maybe a friend calls, interrupts just to ask how the day is going. They decide to change their mind, they tell their friend what's going on, they bring them to the crisis center, and then hopefully they're willing to engage in services. But again, the keys are all these escalating behaviors when we're talking about recognizing a crisis. So again, kind of the same thing, but with somebody that's experiencing maybe a psychotic episode. Maybe this is an individual that is living with schizophrenia, or we see psychosis with drug use. A manic episode can turn into into psychosis, and so. But again, if we look at the baseline, somebody that's living with schizophrenia may have paranoid thoughts all the time. That doesn't necessarily mean the person is in crisis. They can function at high levels with the paranoid thoughts, with active hallucinations. But if there's increased stressors, those types of things, right, we can start to see some of these behaviors escalate into maybe the client sitting at home, he hears the neighbors talking, mix that with the paranoid thinking. The client may think that the individual, the neighbors are talking about them, so they start to stay up all night to watch the neighbors to make sure they're not trying to sabotage them or anything. They stop taking their medication, which can have drastic effects. The client stops eating, again, hygiene, sleeping, and these are all noticeable behaviors. But again, that's the key, right? We want to clue in onto these things, because if we don't, right, then it can turn into a full-blown psychotic episode. Maybe the client comes out and starts yelling at everybody. Maybe there's some threats, those types of things when they reach that point. EMS is called, law enforcement is called. They bring the client to the crisis center. Hopefully we can help them out, and we'll kind of get into that a little bit later. But hopefully they're willing to engage in treatment as that tension reduction, as we see that kind of decrease. So these are just two examples that I gave, and I'm asking you to look at the behaviors, because the behaviors are really non-clinical signs of mental health and an increase in mental health disorders. And so as peer supports, right, you don't have the clinical knowledge and clinical understanding and clinical training, whatever, but you can identify this, right? We can all identify somebody that hasn't slept in a while, that's not eating, that's losing weight, that concentration is hard, withdrawal, right? Clients stop seeing you, they start canceling appointments. And so it really doesn't matter what diagnosis they have, because as we look at this slide, and you can look through them real quickly, that these are some of the more common mental illnesses. They all have very similar behavioral consequences, right? Weight loss, weight increase, poor concentration, sleep disturbances, poor grooming, hygiene, poor appetite. You can look at all those. And so it really doesn't matter who you're working with, right? We can all identify those behavioral changes. And as peer supports, you are more likely to see these things than maybe me as a clinician or a case manager or a med manager, right? Med management maybe is once every 3 months. Well, if somebody's doing this for 3 months, by the time they see the med manager, it's way too, it's over by then, right? We're in full-blown psychosis, or suicidal ideation is at an all-time high. But as peer supports, if you're seeing a client once a week, twice a week, every single day, whatever your schedule is with them, you can see these things. And that's why it's so important for things like documentation. If we're doing mini mental examinations every time we're seeing the client, right? Oriented ×4, or client was dressed not according to the weather, or hygiene. I noticed that hygiene suffered this week when I saw them. I noticed that they're losing weight. Doing those risk assessments on your notes every time you meet with them. That's why it's so important, because if we can identify these things early on, right, instead of that crisis curve being a roller coaster level, right? If we can intervene early, then maybe that crisis curve is more of a speed bump instead of a roller coaster. And so if you identify that these things are happening, then goal number 1 is to get them back on their routine, right? Focus on the sleep schedule, focus on some of these other things, focus on the stress that is causing these types of other behaviors, and do that as your team, right? You're the therapist, the case manager, all the supports that the client has with them. It's so important to do it as a team, but as the individuals that are out in the homes, right? Peer supports, case managers, CVRS workers, they're the ones that are going to see these things first and foremost. And so then again, goal 1, it doesn't matter if you were working on whatever the goal was. If you start to see these things, this should really become goal number 1, is to get them back on that routine, because nothing else is going to matter if they go into psychosis. And so that's key as far as what to do when you start to notice that. So those are behaviors on that, and those are things in general when it comes to a crisis, and how to, if we can identify that early, we can hopefully avoid that. Verbal de-escalation, this is really for a client if you're meeting with them and, right, they're getting into that crisis, or they're escalating. This is how to talk someone down from a crisis if they haven't reached those high points. And so verbal de-escalation is something that we use at the crisis center on a daily basis. We have security, but this is what they're armed with. They're armed with verbal de-escalation. We're not armed or anything like that. And so I can attest to this, that this works, this is effective. But again, we have to know when to use it and when the appropriate time is to use it. And so again, if we're thinking of the curve, the crisis curve, at baseline, right after baseline, that first little section is anxiety. So we're starting to notice that change in behavior. And so just think of a time when you've been anxious, right? And what does it look like when you're anxious? When I get anxious, right, I get fidgety with my hands, like I am presenting now, right? My hands are all over the place. Maybe some pacing, withdraw from social situations, tapping the foot, some of those things. When we notice that with clients, right, that's anxiety. That's kind of that beginning stages of a crisis. And so how we respond to that, we respond in a supportive way. If we see the anxiety, we support. We're empathetic, we're non-judgmental, and we listen and we allow time. This is anxiety. We haven't lost rationale yet. They're not too flustered, right? There's still time to sit down and just be calm, listen, and allow time. That is huge, right? If you have the time, let's sit and talk about this for an hour, and let's figure out what's going on, because we have that time, we have that luxury. Because if it goes into the defensive stage, which is that next level in the crisis curve, we're beginning to lose rationality, right? That's when shouting, refusal, getting defensive, that's when, right, the client starts to shut down. and trying to talk somebody, right? Having an in-depth conversation while somebody's shouting, it just doesn't work, right? Anybody that's been in a relationship, right? We all get into these modes sometimes, and if it gets to this point, there's no more rationality, there's no more, let's just talk it out. And so how do we, when somebody's in this mode, what do we do? Well, we need to be directive. And so that is simple directions, and we need to set limits with somebody that's in this stage. Again, we don't need a huge conversation at this point. It's just simple, direct limits. So at the crisis center, it may be something as simple as, Joe, I need you to step outside. Joe, I need you to step outside, right? If somebody in the client's name is Joe and he's escalated and he's kind of getting other clients, triggering them and kind of causing an issue, and we just want them to step outside. Let's go take a walk. Let's get some fresh air. But I can't say all of those things because it's too much, right? And so to be simple and straightforward, Joe, let's step outside. Joe, let's step outside. Repeating it so that way it's simple, it's going in, and eventually the client will hear it. If not, then setting limits. Joe, if you don't step outside, I will have to call the police. I'll have to call law enforcement, or we're going to have to discharge you at the crisis center. And, you know, some of those things, if you aren't going to follow the simple direction, this is what's going to happen. And just repeating that over and over and over again, really to help the client kind of get past the shouting and those types of things. If the behavior doesn't get better, if that doesn't work and we're continuing on up into that, the risk behavior, right? That's when we start to see that harm to self or others, right? Hitting either themselves or others around them, throwing things. This is really where we disengage. I would encourage everybody here to disengage and really understand what your policy is at your own agency when somebody becomes violent. Everybody's different. Everybody should have their own policy on what this is. And if you don't know it, you need to go talk to your clinical supervisor to really understand, what am I supposed to do if somebody gets violent? You need to know that. At the crisis center, again, we use verbal de-escalation, no hands-on or anything else. If somebody gets violent, we try to get everybody else to a safe location, kind of isolate the client as much as possible and call law enforcement and have them take control of the situation. And so we disengage, call law enforcement. That's our policy. Any of these, in any of these situations, right, that tension reduction at the very end, that decrease in energy, because becoming defensive, anxiety, you know, hitting, punching, you know, all of that takes so much energy, right? Being anxious all day for an exam or, you know, something really important, at the end of that, right, we're just physically exhausted. It's like, well, I didn't even do anything. Well, being anxious, being defensive, all of that takes an incredible amount of energy. So we see that tension reduction at the very end. Sometimes there's crying, apology, you know, I'm so sorry, I can't believe I did that. I've never swung at anybody, or I've never yelled profanities at anybody. I'm so sorry, I can't believe I've done that. That's not like me. That's that tension reduction side of the crisis curve. And at that point, how we then would approach that is to reestablish communication. Again, we have that time to sit down with them, debrief the situation. And this is really where somebody will, it's kind of that pivotal moment in life where, you know, you kind of get that clarity of, okay, do I want this type of behavior to continue, or do I want to do something about it? And so if we can approach the individual at that time and really talk about the benefits of treatment, you know, that's a good time to get somebody connected to care and really kind of get that buy-in to, all right, maybe treatment is going to work. I'm tired of doing it this way, and I want to move forward. So this is a pretty busy slide. This is one of the more busy ones, but again, as we're going through those stages, the anxiety stage, the defensive stage, the risk behavior stage, I can't exactly tell you what to say because every situation is different. There are a few trainings. ASSIST, A-S-I-S-T, is a 2-day training on it was described to me as if somebody's sitting on a ledge ready to jump to commit suicide, this training would train you how to talk somebody down. Mental health first aid is a training. It goes through a lot of the common mental illnesses and teaches you how to talk somebody down from a panic attack and some of those more specific things. So there are trainings out there for more specific things on exactly what to say. This is more of in a general way how to talk somebody down. And again, your personal experience with the client is going to mean a lot, right? So I can't tell you what to say, but I can tell you, you know, here you need to be supportive. Here you need to have simple directions. But it's not only what we say, but how we say it and how we're standing, sitting, positioning ourselves is very key as well. And so we're looking at the nonverbal and the paraverbal side of communications. And so on the nonverbal side, we're looking at the space between two people, you know, how much distance is between you and the client, right? And that's going to depend on a lot of different things, right? How long have you been working with the client? You may feel comfortable being closer to them. What's the gender versus your gender, your culture, their culture, all of those things come into play. And so really understanding that your body language, your gesture, how are you standing, your movements with your hands, right? If the client's in the anxiety stage and we're being supportive, we're allowing time and we're trying to present a sense of calmness, right? Our body language is going to look different when the client's in the defensive stage and we're giving simple directions and limits. Same thing with our paraverbal, right? The tone of our voice, the volume of our voice, and the cadence of our voice. If I'm being supportive, the quality, the pitch of my voice, right? I'm going to try to give us a smooth, rich tone to the client, not loud, maybe a little less than loud, right? Maybe more of a soft voice, and the rhythm nice and smooth, right? Nothing too rushed. We're slowing down. We're giving the client time, because if somebody is anxious and we give them anxiety back and we're anxious back to them, we're only adding fuel to the fire, right? We want to model what we want to see in the client. So we need to be in our verbal, our paraverbal, and our nonverbal. We need to show that as well, which again is completely different if the client is in the defensive stage and we're giving simple directions and limits, right? And so the personal space is going to be different. We're going to be a little further back from the client, right? And that's where the supportive stance comes into play, right? We want to be one leg length away. That means they can't swing. If they do, they can't reach. If they kick, there's no way that they can reach it because you're one leg length away. At an angle, and so hopefully you can see the picture. The individual on the left is at a stance. The individual on the right is standing square up to the client or to the other individual. And so the supportive or the at an angle stance gives you the weight on your back foot. And so if the client were to lunge, attack, or whatever, you have that back foot to fall back on and you're less likely to get toppled over, right? You push the guy on the right on the shoulder and he has to take a step back before he can catch his balance. And so supportive stance, arms at the side, not in your pockets, don't hold anything, right? And that shows that you're not a threat, but also you can bring your hands up if you need to. And also it allows for personal safety and escape route if you needed to turn around and jet out of there, right? If they get to that risk behavior stage and you need to disengage, you're already turned and you're already on your way out, right? I'm a runner, and if I'm running and a dog is coming up, right, the last thing I want to do is square up to it and pose myself as a risk to the dog, right? I would try to be as non-threatening as possible. It makes you look smaller when you're at an angle, so you're less threatening to the client. And yeah, so the nonverbal and paraverbal communication. There's a full training on this. This is CPI training from the Crisis Prevention Institute. And so again, there's a whole training that goes just into this slide, the verbal de-escalation, and this. There's a whole, I think it's an 8-day or 8-hour training on just this. And so again, that's something to look into if you wanted more information on that. All right, so that's the end of one. Anna, are there any questions at the moment?
Hey, Matt. I don't see any questions that have come through regarding the content so far.
Okay, awesome.
If you see a few roll in the next few minutes, I'll just pop on and let you know.
Okay. All right, and so the next stage is learning the appropriate crisis resources. And so understanding when somebody's in crisis, right, what exact resources should I use? When do I use the hospital? When do I use the crisis center? When do we use the emergency numbers? And so first off, I would hope that everybody's trained in safety planning. I really like the Stanley Brown safety plan because it gives, I think there's 6 different steps on it, and they don't have to be used in chronological order. You can jump. If you feel like you need 3 right away, then use 3 right away. And it gives you, right, intervention 1 and 2 are more casual steps, right? Who's a friend that you can talk to, not about your suicidal thinking, but just somebody to reach out to that you can just talk about the basketball game last night or something to distract yourself. And then the next level is, well, who is somebody you can contact and talk to about your suicidal thoughts? And so it gives you a whole range. And as a professional, right, that's really easy for you because you can talk to the client, know where they're at, and then refer to that safety plan exactly right where they need to be in their own recovery in that crisis. And so that's a great safety plan. I really encourage you to look into that. Again, there's a whole training in that. I think it was a 2-day training that I took to be certified in that. But it's a fantastic safety plan, and it really, again, gives you that structure of when and what to use some of those things. So when do you use a crisis center, right? And so I wouldn't be doing my due diligence as a director of the crisis center if I didn't talk about crisis centers for a second. Crisis centers in Idaho are all state funded, and so there are currently 7 of them in the state. And so I don't know where everybody lives that's on this call, but there's 7 in the center, 1 in each region. And so find the one that's closest to you, write that number down, call and ask for a tour, call and ask if about it, you know, what are some of the different nuances, because we're all a little bit different. Some of the things I'll be reporting on, I can talk about my center in Pocatello, and I can talk about the center in Idaho Falls. We're run by the same company, and so we're pretty similar in what we do. But really, crisis centers were developed to fill the gap between outpatient, so your counseling agency, and some of those community supports, and the hospital. And so if they're not severe enough in their crisis to need inpatient treatment, but in the office, the crisis is beyond what can be done in the mental health office, the counseling agency, then that's really where the crisis center falls into place. Here in Pocatello, we really don't define what a crisis is, because I want to be as open as possible. If somebody comes in and they tell me they're struggling with their anxiety, to me that's a crisis, because I want to help them. I want to intervene as quickly as possible on that crisis curve, because if I can intervene right way sooner, then we can avoid a whole lot. It's less interrupted for the client, it's healthier, and all of those types of things. We are mental health and substance use, so anybody struggling with their mental health or substance use. We are adult facilities and those types of things. But as peer support, we should really be on your safety plans for everybody, every single person. All of your clients should know about us as the crisis center. We are a free service. We're open 24 hours a day. There's little to no barriers on getting into the center if you're in crisis. In Pocatello and Idaho Falls, I know I can at least talk for them. I don't want to talk for the other centers, although they're pretty similar. We're going to help you. So please use us. Please understand what we do and how we help. It makes your job easier, right? You're not struggling like, oh, I don't know what to do with this client. I don't feel like I can help anymore. You know, come down to the crisis center. You, again, here in Pocatello and Idaho Falls, you can come through the intake process with the client. If they need that support to come in and go through that process with them, that's 100% acceptable. The more, right, research shows the more help the client has, the better off treatment's gonna be. So So how to appropriately use the crisis centers, the hospital, or calling law enforcement. Again, we're going to go back to those behaviors that you've identified in your client. Hey, my client hasn't been sleeping. My client hasn't been eating. I'm really worried they've stockpiled their medications. So when you're calling the hospital, if you're calling us, if you're calling law enforcement, right, you want to be as brief and to the point as possible. I don't need to know what happened a year ago at this moment because they're in crisis, right? We need to get them help as quickly as possible. So I don't need to know what happened a year ago. I need to know what's happening right now. And so instead of saying something like, my sister is behaving strangely, or my client is acting really weird, you might say something like, hey, my sister hasn't slept in 3 days. She hasn't eaten anything in over 5 days. And she believes that someone is talking to her through the television. Right? That's giving me behaviors over the last 2 or 3 days, and I can assess how severe it is, and it's quick, right? That was 3 sentences, and it gives me a ton of information instead of my sister is weird right now. And law enforcement I know that they would enjoy having that right brief and to the point, letting them know if there's any threatening behaviors, threats to others, pacing, irritability. That way, right? If you get you can always request a CIT officer as well that's been trained in mental health, because if they're in the anxiety stage and they're pacing or they're irritable, and you can tell law enforcement that, then when they show up, they're gonna expect that. If they don't expect it and somebody's pacing, right, they're gonna see that more as a physical threat, and it may take action that doesn't need to be, right? We can still talk to them at that point. So giving them a heads up is huge when reporting these types of things. So again, these behaviors are super important. And so what do you think we do at the Crisis Center to help? Well, we focus on those first 2 sections of the pyramid, right? In the Crisis Center, I have 20 beds, I have a shower, we have laundry, we do 3 meals a day. I have clothes for the client to change into. We can meet the client socially, and we can satisfy those first 2 rungs in the pyramid. Because if we do that, if we can get them back on track, sleeping 8 hours a day, eating 3 meals a day, a shower, some social interaction, anybody that's coming to the center, if I just did that for 2 or 3 days, I see an increase, a healthy increase in most of the clients that come into the center. It is such a undervalued tool because it feels so simple, and it is, and that's why it works. And so that's our #1 intervention at the Crisis Center. But we have the facility to do that, right? And that's really where using us is important, because instead of just leaving the client at home, you work with them, send them home. They don't feel safe, they're still not eating. You know, here we have medical, we have security, we have a psych tech who can help them out. And then of course we have our case managers who build treatment plans and those types of things, and gets them further care. But this is what the Crisis Center does. We have the facility to satisfy those first 2. That way when we release them back to you, hopefully they're back into the middle rung of the pyramid, and then you can get back to working on whatever you were working on with them. So that's where we fit. Unfortunately, if we can't take care of them, then we would get them up to the hospital and they would do their treatment up at the hospital. But unfortunately, just because they go up to the hospital or they come to the Crisis Center, that doesn't mean that everything's fine, right? They're good, they're better, we're over it, we don't have to worry about it. However, getting them into inpatient or the Crisis Center isn't the end of the crisis, unfortunately. If somebody goes into the hospital for a mental health reason, suicide rates are 100 times the global suicide rate during the first 3 months after discharge. And if somebody goes into the hospital with suicidal thoughts, admitted to the hospital with suicidal thoughts or behaviors, rates are nearly 200 times the global rate after discharge. So that means just being released, that is a high risk time. And so again, as peer supports, this is crucial just because somebody is out doesn't mean that everything's better, right? We still need to focus on these things, and we still need to keep a close eye on these behaviors to make sure that we can hopefully reduce some of these numbers, right? If we identify that, hey, this is an issue, this is a high risk time, I need to keep my P's and Q's, I need to be ready to focus and work on this. So yeah, super important time. And that's where our peer support out of the crisis center works with individuals at discharge. And then our peer support is able to follow the client after discharge for 2 or 3 months until we can get them set up into long-term treatment in an outpatient setting. And so hopefully our goal is to reduce this rate of suicide after discharge from the crisis center. We can continue to support them so they're not falling into any gaps or any holes in the community. You know, hopefully that's one of the ways that we can address that issue. Just 2 more slides, Anna, but are there any questions? I think 15 minutes?
Yeah, there. I don't see questions yet. We have 2 comments. If you wouldn't mind me just reading those.
Yeah.
So someone mentioned, I have a tour. I've had a tour at the crisis center with my agency. I have also taken peers as a certified peer support specialist to see it in order to decrease anxiety if we needed to go there. I would highly recommend peer supports be educated on the center and procedures. The next comment is, I've supported a peer with going to a crisis center before and it helped a lot. Much less weight and much less stress in the ER that they were used to, especially during the pandemic. So.
Yeah, that's great feedback. I'm glad that the crisis centers have helped, and yeah, our intake process, you know, I use the example of if law enforcement brings somebody to the center, it's a 15-minute drop off. If law enforcement brings somebody up to the hospital, they're up there for about 4 to 5 hours on average. Our intake, you know, you go through a mental health intake and a medical intake, and that could be a half hour, 45 minutes. It's so quick. We try to make it as easy as possible. We understand that this is a difficult time, but we want to be an intervention before the hospital. We want to let the hospital deal with what they need to, but we're here for really anything. If they're struggling, bring them in, get to know your crisis center, and yeah, that's great feedback. Thanks, Anna. So the last 2 slides. The unique aspects of crisis work. Number 1, and this is a shift in all of our minds when we started the crisis center, is time frame and goals. If somebody's in crisis, the time frame and the goal of your intervention shrinks, right? I talked earlier about if you're starting to see these behavioral changes, whatever goal you were working on, right? Getting out of the house, doing some of those things, that needs to change, right? Our goals need to change. The time frame needs to change because this is something immediate and we need to get on it as soon as possible. At the crisis center, you know, our treatment plans are for 1 day, maybe 2 days. And so we have 2 days. What is the goal for the next 2 days? And so it is such a shift in thinking. Me coming from outpatient doing therapy, right? I would write a year-long treatment plan. So over the next year, this is what we want to work on. And so it was a huge shift in my own brain where I had to think, okay, for the next day, what is our goal with this client? And it's such a shift, and it's something you really have to think about, and it makes your efforts super meaningful, right? There's no wasted time, there's no wasted space. Those goals need to be as clear as possible because they need to mean something because it's such a short time. The interventions need to change and super simple steps because again, if they're in that crisis mode, it's hard to do something that's super convoluted. They need a lot of support at that time. And the expectations, right? What are we expecting the client to do? What are we expecting them to know during a crisis? And I run into this occasionally at the crisis center where you know, we have somebody in the building that's coming down from methamphetamine or from a psychotic episode or something, and maybe they're rude, maybe they're a little crass, maybe there's some different things going on, and I get feedback from staff of, but they're so mean, and they're not following the rules, and they keep doing A, B, and C. But if this is somebody in a mental health crisis, this is somebody that somebody on probation, some of these things that we, where are our expectations, right? Their ability to function is limited. And so what are we expecting them to do when it comes to their goals and things like that? Or why do they keep coming back? Why is this crisis the same crisis every single time? And so really understanding the cycle nature of mental health, right? The cycling of a depressive episode, manic dates that affect suicidal ideation, understanding those and working with the client where they are, and understanding your own expectations with your own mental health is super huge. And so, and then the last slide, right? We can't get away talking about crisis without talking about self-care. However, there's a big challenge that I want to challenge everybody in really starting to separate self-care versus self-soothing. Working in crisis, working in an ER setting, an inpatient setting, at a crisis center setting, or just working with clients in crisis is very difficult. And as a peer support, if you're coming from a place with personal history and you're doing well in your own mental health management, seeing somebody in crisis can really be triggering, and seeing those symptoms intensified can be harmful to yourself. And so really taking the time and understanding yourself, debriefing with yourself, doing your supervision with your supervisor, and communicating those things in a healthy way and an honest way is so important, because the burnout is incredibly high. But separating self-care versus self-soothing. And so I think when we talk about self-care, like, oh, how are you taking care of yourself, right? What are you doing for your self-care, right? I hear things like, oh, well, I took a bubble bath, and I put on my favorite TV show, and I read my favorite book, and I took a walk with my dog, and or I played with my dog, some of those things. And those things are fantastic. Those are absolutely great. And we all need to have those things that we can do. However, those are self-soothing techniques, right? I had a busy day, a stressful day, my stress is up to here. I took a bath, and now my stress is down here, right? All we did was soothe the stress, again, which is fantastic. However, those are short-term, and I can't eat brownies and cinnamon rolls every time I'm stressed, right? That would make me feel better, but over the long term, that's not going to be healthy long term. And so self-care is really that doing the hard things now so future you benefits. And that's what self-care is. Self-care is hard. Self-soothing really isn't, right? The bath is easy, right? Getting into the bath, sitting there, relaxing is fantastic. Self-care is eating healthy so that your cholesterol goes down, so that you can live longer. Self-care is doing the exercise, and so that you can lose that last little bit of weight that you're looking at. Self-care is addressing your own trauma and doing your own therapy so that you can be a better peer support moving forward. That's what self-care is. And so really understanding when you're putting your self-care plan together, you're identifying what is self-care and what is self-soothing. Self-care for me, when the pandemic hit, right? I'm running a crisis center in the midst of a pandemic. I have a small family with young kids, right? A lot of stress. And so I had to find something. I couldn't do some of the normal things that I used to do, a lot of social activities, all of those things. What am I going to do? So I started running, right? There's something I could do by myself. It's something that didn't involve other people, so I didn't have to worry about COVID. I've never really done it before. And so it was a new thing, and I thought, well, this is something, right? We'll see if it works. And so last March, I started running, and I picked up a new hobby. I found out that I loved it. I've lost a ton of weight on it. It clears my head when I go running, and it has benefited me, and it will benefit me long term, right? That's self-care. It was not easy putting on 4 sweatshirts and running at 8 o'clock at night all winter when it's 20 degrees outside. That's not easy, but I did it consistently, and that's that self-care, and it is a hobby hopefully that I use the rest of my life, but that's something that will benefit me long term. That's self-care, right? Coming home and eating the brownie after I go running is self-soothing because of the self-care, right? And so so as you're working on yourself, identify these, make sure there's a good balance, make sure you're challenging yourself for your self-care, because that's really where that long-term work comes from. So, but I believe that's it. Anna, are there any questions or comments? We can open it up.
Yeah. Well, first of all, Matt, thank you for that presentation. I just really appreciate your willingness to come and present with us today, and we're just super lucky to have access to someone like you who just does so much great stuff for our community. So I appreciate you so much. Let's see. You're just getting comments on that you did an excellent presentation. Another comment about from someone talking about they provided QPR training for crisis volunteers and students, which is awesome. We have a quick question for you. Do the crisis centers bill Medicaid and True Blue, or are they funded through another source?
Yeah, so we are primarily state funded. To help sustainability, we have been able to start billing Medicaid. We are credentialed with True Blue and Molina, and so we do that on the back side of things. And so it's not anything that the client has to worry about. If they come in and they have Medicaid, but they don't have their Medicaid card, you know, we're not going to deny them or anything like that. If we can bill, we bill. If we can't, we can't. It's about I think 30 to 40% of individuals have no insurance at all. And so that's not a worry. That's where the state funds really come into play to make sure that we can target all the populations, whether they're insured or not.
Awesome. Thanks, Matt. The next question we have is, what was the 2-day training about crisis response you referred to earlier?
CPI training. So that's from the Crisis Prevention Institute. So Optum, and so if you're working within an agency, you can contact Optum and you can get them to come. I believe there's a charge for the training, but Optum does have CPI trainers that can come down and train your staff. They put on a training up at the hotel here in Pocatello, and we trained all of our staff. It's a requirement for us at the crisis center that our case managers are CPI trained. But it's a great training. And there's a lot of role playing, a lot of some of those skills that we talked about, a lot of this is how to do it. This is a chance to practice some of those things.
Awesome, thanks, Matt. Was there another training you mentioned that was referring to safety planning?
Yeah, so Stanley Brown, their safety plan. There's a training that you don't have to be trained to do the safety plan, like you can print it off and use it. But I would suggest if it's something that the agency wants to do, you can do a 2-day training in order to train others on it. And so, because there are certain steps and a certain way to use it. So, but it's a fantastic one, Stanley Brown. Okay. And you mentioned QPR. QPR is a fantastic training as well, for sure.
I used to be a QPR gatekeeper trainer. My license lapsed, but I might up that again because those were amazing classes.
Yeah.
Okay, so seeing if we have any more questions. So we can hang out for a few minutes. We do have 2 minutes technically. So any more questions, send them my way. In the meantime, while I have everybody, we have an evaluation that will automatically go out after this session, and we really encourage you to complete that evaluation. It's not only helpful for Empower Idaho, it's also helpful for Matt, because we do share those with our presenters. And it's a great chance for you to kind of share your experience with us, with our presenters, but also you can suggest future topics. We really like to make sure that the topics we provide are topics that are, frequently requested by the community we're trying to educate. So it's a great chance for you to give your feedback. We really do listen to those evaluations. That's how we selected these training topics for this series.
Yeah, and if I really enjoy doing these trainings or talking about the crisis center, and so anybody that would like me to either come or over through Zoom, talk to your agency about crisis centers or anything like that, anything I can do to get the word out, I'm 100% available and want to do that. So just let me know and we'll set something up.
Great. Matt, do you mind if I share your email in the chat box?
Yep.
Okay. It's the one at Best LLC.
Yep.
Sounds good. Matt's email is going into the chat box. He has said it is okay to reach out to him. He just said that. So please utilize that email. It's awesome that we are able to communicate so closely with someone like Matt. So there it is right there. I don't see any more questions coming through at this time. But if anyone who's attending has questions for Matt, there's his email. You can pass them through me as well. Questions about the CEUs or how that process works, please email me. My email address, I'll put it in the chat box as well, is right there. And I'll also put Erin Moore because she is our project assistant and she will be creating all of your CEU certificates. Thank you again for joining. Matt, thank you so much for your time. We're going to be in touch about other trainings potentially with you that are crisis related, so we just appreciate you. Again, evaluations, we would really love if you filled those out. Other than that, hopefully we'll see the rest of you at our next 2 sessions today. And Matt, have an awesome weekend and we'll talk to you soon.
Awesome. Thank you.
Yeah. Bye, everyone.